May 14th. And this morning we have in with us some students from Middlebury College who have spent their semester doing research around various healthcare topics. They presented their findings and research to us a couple of weeks ago here in the State House. And as many of the topics sort of cross what things we're working on, decided to have you all in so you can give us a little bit more of an in-depth presentation. First up, we have Jonathan Brooks. So thank you for being here.
Thank you, Chair Block. Hi, everyone. As Chair Block just said, I'm Jonathan. I'm a junior at Middlebury College, economics major from Austin, Texas. And I first want to thank you all for having me. It was spent 3 months on this project, and I think there's a lot of valuable insight that we've all learned. Fortunately, my other two group members, Emma and Liam, couldn't be here today, but I hope you can gain a little more knowledge from my presentation. So I'll just share that. Okay, so I'll begin just with kind of a layout of I'll be going through the risks and benefits associated with private equity acquisition in healthcare in terms of quality of care, price of care, organizational financial practices. Then I'm going to kind of shift gears, talk a little bit about some key legislation from Massachusetts, California, and then also roll right into H71. And then I'll kind of highlight a few of the recommendations, or at least things that we found in our research group that might be worth considering for H71. So just to begin, I really wanted to just start by highlighting both the rising impact nationally and statewide of private equity and how in healthcare. In terms of this graph, it's just you have your capital invested kind of monumentally rising over the past 18 years and the deal volume increasing as well. So clearly, private equity has taken an increasing interest in healthcare specifically. And the second graph is just from what's the private equity risk index. It's a really interesting group that has decided to take all 50 states and through their methodology, take data, compile it along with healthcare, housing, pension funds, and assess how at risk that state is for practices that would be considered less than ideal from private equity. In terms of Vermont, they actually have it at a 46 out of 100, but that's the overall rating. It's actually much higher in healthcare. It's about 66 out of 100. And a lot of that is contributed to, I'll get to it a little later on in the presentation, but nursing home ownership percentage in private equity, along with our lack of corporate practice of medicine laws. Okay, so these were two quotes that we were able to compile from our research. Our research basically consisted of looking at peer-reviewed studies along with interviewing people in and around the industry. We had, the fortune of talking to both a managing partner at a private equity firm and a physician who was in another state and had worked for a hospital that was then acquired through an MSO by a private equity firm. And as you can see, there's two very conflicting points of view here. She had quite a poor experience with private equity, whereas, our managing partner at our PE health firm was, much more positive about the impacts that could happen when private equity is allowed to invest. So in terms of actual data, we found there is some conflicting evidence in the literature, and a lot more of our quantifiable data is negative, whereas you have some more anecdotal data that can show, this could actually be pretty useful. But just in terms of the negatives, some of the stuff that stood out to us was a 25.4% rise in hospital-acquired conditions. This could be for a number of reasons, but these are in hospitals acquired by private equity. And it mostly speaks to either a lack of proper standards of care or a potential a potential of cost cutting in the hospital. They also, the same study also found a 27.3% increase in falls and a 37.7% increase in central line associated bloodstream infections. Basically, again, speaking to standards of care kind of falling back, and quality of care falling back. And then in nursing homes, especially, one of the most surprising points for us was an up to 11% increase in mortality, just straight up across the board. There were higher quality scores for heart attack treatment in certain private equity hospitals and lower inpatient mortality rates from heart attack in some private equity hospitals, which could also speak to improvements in standards of care versus regression. So the data, it's conflicting evidence. It's really hard to tell what's what, but a lot of, in terms of nursing homes and hospitals, there's a large risk that can come with private equity acquisition if there's no regulation in place. So in terms of price of care, overall net increases in price. Hospitals had about a $407 increase in total charge per inpatient day. So per day, not per year or anything, but per day. And then in about 578 practices across dermatology, gastroenterology, and ophthalmology, another average increase of about $71 per insurance plan. Okay, so in terms of financial practices, consolidation. Private equities like to do things called roll-ups. They buy a bunch of smaller practices, roll them up together to create a care network. This can have numerous implications in terms of antitrust and monopoly. So review, in our opinion, is really important in this case. It also pushes out independent providers and, like I said, increases healthcare prices. Increased expenditures. So one study we found, it's Gupta et al. It's a 2021. I think it's a consolidation of a bunch of studies. It noted 3 areas that increase after private equity buys out a nursing home. And those 3 areas are monitoring fees, lease payments, and interest payments. And these can be in the form of literally the private equity firm sucking money out through a real estate investment trust or something of that nature, where they're buying the land that the practice is situated on and actually charging them more rent just to maximize their profitability. There are some positives in terms of economies of scale. Like I was saying, those care networks, it can be beneficial to both providers and patients by increasing efficiencies in care and also like getting care to patients and having care in an area and making sure people can get to care. There can be some increases in efficiency there. So the key legislation, California Senate Bill 351. This is was one of our favorites in terms of corporate practice of medicine. So it's actually been just recently, May 12th, it was placed on suspense file by their appropriations committee just to look further into the fiscal impacts. But it prohibits outright interference with clinical judgment, which is something we felt was really important considering private equity deals within healthcare, like other areas, are focused mainly on short-term gain, which isn't always conducive to, like I said, quality of care, price, and financial practices. So actually preventing them from indirectly or directly influencing clinical judgment is something that we felt was probably the most important aspect of legislation. And the California bill does a really great job of concisely, but also in some detail, listing out the practices that they're not really allowed to do that could potentially harm patients. It also had some contract clauses for non-competes and gag clauses, which we felt were really important considering the physician we had talked to, who is now based in Vermont. She had quite a poor experience with private equity, I think. The private equity firm that acquired her hospital through an MSO had cut her health benefits. I I think, doubled the amount of patients that person was seeing, and then also had them under some sort of non-compete gag clause. And they were actually advised by their lawyer not to talk to us. So we're trying to keep them as anonymous as possible. But these gag clauses and non-competes make it really hard to tell what's actually going on. And California did a really good job of just outright not allowing them or making them unenforceable. The California bill also does a really great job of enforcement in terms of violations of any CPOM legislation. So it just says the Attorney General has the power to enforce any violation in this legislation just outright, as opposed to being forwarded to them and kind of getting kicked around.
You said this was one of your favorite bills. Is it only because it's sitting in their version of appropriations?
Yes, it is still my favorite of the ones that could be incorporated into H71 or looked at, but it just, it's still sitting there and we don't know what's going to happen. There was one that was recently vetoed by the governor. I don't know if it's in the last year or not, but so I'm not sure what's going to happen to this one. This one's much shorter and it's a lot more concise in its language, so it might have a better shot of going through. Still not sure. So Massachusetts, H5159. This bill is much better in terms of review and transparency. One of the other aspects that we were pretty concerned with. It requires notice and review of ownership, control changes, and especially if they make impact on market share or costs. And it does this through, I think it's a market review, some sort of market impact review. That's what they called it. Cost and market impact review, which is something that we thought could be incorporated into H71. It also requires ownership disclosure, post-transaction monitoring, another great aspect of the bill, and cost market impact reviews, like I just said. And this is the only bill that's actually we're looking at today that's been passed and is law. It also expanded financial and ownership disclosure requirements for provider organizations, especially those involving, private equity, REITs, MSOs, all ways of indirectly owning healthcare. The one thing it doesn't do is address gag clauses or non-competes, which California does pretty well.
Can you say what an MSO is? Sorry.
Yes, it's a management service organization. So initially, their initial purpose is different than what they're used for now. And I'm obviously not a great expert, but nowadays they kind of are third parties that can manage administration in a hospital, I think. Mm-hmm. And then those organizations get acquired, and indirectly you can have someone above that MSO influencing policy in the hospital.
Thank you.
And or healthcare organization. Okay, so H71. There's a lot in the bill that is really amazing. We read all the way through it. There's a lot in the bill. It's a long read for finals week, but there's CPOM legislation in the bill. Vermont currently has no CPOM legislation. We thought, of all things, that is the most important thing to look at and just consider. The limiting of debt levels and financing arrangements used by PEO and healthcare entities, also extremely important. Also prohibiting restrictive contracts by banning these non-disclosures, gag clauses, and non-competes. Another thing just to improve transparency and promote, protections for those who see something going on that they think should not be, and allowing them to come to someone and actually seek justice and improve the healthcare system. Transparency requirements, they're in there and they're pretty good. There's a couple things we thought we could bring in from the Mass bill, but I will get right to that. In terms of limiting debt levels, we just think this is important because it prevents models that prioritize the short-term profits over long-term stability, like leverage buyouts and recapitalizations that are most commonly used by private equity firms. These restrictive clauses, they limit, like I said, limit clinicians' ability to advocate for patient care or change employers, which is really not helpful when you're trying to promote growth in a healthcare system. And the whistleblower protections, just to go over it again, it's to safeguard those healthcare workers who report actions by management or parent companies that compromise clinical integrity for financial gain. Again, we do not want that. And just for subchapter 1, section 9525 of H71 on transparency, we felt mandating public reporting on financial practices, executive compensation, political activities, and healthcare costs by PE-owned facilities was extremely important. The transparency requirements help safeguard against predatory practice, and it empowers consumers with the essential information about their healthcare providers. Specifically, the section on having the $1 million reporting threshold we think it's great to give to the Green Mountain Care Board and then forward to the Attorney General if there's an issue. Just in terms of what I said before, roll-ups, where a bunch of private practices get bought up in an area. If you have that $1 million reporting threshold, it can be a lot easier to find out when that's happening and how broad it's spread. In terms of what could be stronger, and this is, a 21-year-old college student. Don't take
An
offense.
amazing 21-year-old.
You definitely know more than us right now.
I only got to page 20 before. This is even saying.
So subchapter 3, we think it should model SB 351 a little more. It's great and it's strong, but SB 351 is a little stronger in its verbiage and gets a little more in detail. So it doesn't go as far in explicitly listing prohibited behaviors. SB 351 sets out a clear and enforceable list of off-limit powers like hiring, firing based on clinical proficiency, controlling patient volume, billing policies, and referral decisions, all parts of a healthcare practice. And adding that to H71 would plug potential loopholes that these MSOs or private equity firms could use to exploit via like a soft control on contracts, like without having actual legal ownership of a practice. In terms of standardized risk assessment to screen acquisitions, we think it could be modeled a little bit more like H5159, because H5159 has a more proactive approach where it builds like a systematic front-end screening process that flags transactions with potential risks rather than relying solely on post-notice discretion of a committee or the Green Mountain Care Board, as opposed to being notified of a acquisition and doing post-acquisition work. You can get in front of it. It also would increase consistency. A standardized tool like a cost and market impact review used in H5159 and would ensure consistent criteria are applied across all acquisitions as opposed to it being a case-by-case basis. It would boost enforcement readiness. So giving the Green Mountain Care Board a formal screening mechanism linked to the Attorney General makes enforcement faster and more targeted, especially for more complex PE-driven deals. And then finally, it complements H71's strengths already. H71 already has a strong CPOM transparency and transaction oversight sections. This addition would make the review process a little more data-driven and a little more defensible. So the big question that we got when we presented was, who cares about Vermont? It's so small, who cares? And to that, I want to run back quickly to the Private Equity Risk Index. They have done a really good job of compiling some Medicare data on nursing homes. And this is just a quote from them, and I'll read it. In addition to it being among the top 10 states for share of nursing homes controlled by private equity, Vermont is among the 10 states with the largest average number of substantiated complaints at private equity controlled nursing homes compared to the average for all nursing homes in the state. And yeah, so in researching this project, our group initially was like, oh, what do we have to, Vermont doesn't need anything, you know, private equity's not coming here. They don't care about it. In reality, past hospitals, we don't actually have a quantifiable metric of whether they're here. It's more like, oh, yeah, my dental practice just got acquired the other day, you know. We don't have a great metric to tell how deep it is in the state. And I'm not saying it's some menace around the corner and there it's everywhere, but it very well is in certain private practices, and certain private practices are far more vulnerable, especially considering Vermont's aging population. Nursing home practices are especially vulnerable. And like I linked to before in the quality metrics, it can go wrong without proper legislation. Vermont has no legislation to regulate corporate practice of medicine. And that is something that we feel really strongly needs to change. It lacks, and we do have our certificate of need laws, but past actual registration of your practice, they're not going to be able to regulate in future. So key takeaway, just in some instances, private equity can equate to positive impacts with the appropriate guide rails. This is the thing our group wants to hammer into y'all. It's private equity can be a net benefit when regulated properly and when kept from going in directions that are negative. The best instance we found was when we spoke to this managing partner at a PE firm, said, yeah, the people who work at private equity firms are human too. They're going to take the path of least resistance when trying to drive profits. You have to make sure that path of least resistance aligns with quality of care, goals, price goals, any goal you have for healthcare in Vermont. You have to just make sure that that path of least resistance aligns. And that's it. I want to thank Professor Holmes for an amazing semester. She was a great help for us all year. Sam Peisch, who you guys probably know pretty well. He sat down with me and he was extremely helpful in putting this presentation together. And he also are anonymous interviewees who, you know, stepped up to talk to us, and it was extremely helpful. But yeah, thank you.
Any questions for Jonathan?
I do have a handout for y'all if you want, comparing the bills, if you want to pass that down.
Yeah, thank you.
There's a little bit of language comparison.
Oh, great.
Go ahead, Leslie.
So you mentioned Rhode Island holding out in one of your.
Yes.
Yes, and Rhode Island seems to be a model of wonderfulness, and just wondering what we can learn from Rhode Island.
So we never specifically looked, we looked at Mass, California, and then Wyoming for, I can't remember why. But we didn't specifically look at Rhode Island. I can't really give you a great answer on that.
Okay, no, yeah.
Yeah, I will speak to the fact that I just want to mention this. It's might not be a question, but in terms of expenditures, there can be some big failures. Prospect, I forgot to mention it to y'all. If not properly regulated, same idea. Okay,
Yeah.
But yes, and back to your question. No, we didn't.
Yeah.
I can't really give you a great answer.
No, that's great. And you gave the link, so that's fantastic. But I just keep hearing about Rhode Island. It just what are they doing? That's so cool. Thank you.
Yeah.
Thank you. Oh, super
Yeah,
helpful.
well done.
It is.
Yeah, thank you so much, Charlie.
You guys.
Work.
Are you graduating?
No, I'm a junior, so I'll be here next year.
Great.
Thank you, and thanks for your work.
Yeah.
Hope you got a good grade.
Very impressive.
We'll put a plug in with the.
Yeah.
Next up, we have, so 3 of you. And we can move a chair from our healthcare advocate, will give up his chair.
There's one over there. Yeah, we are set.
And you can use my desk. And you can use my desk. So, yeah, appreciate that. Absolutely. Gets a little crowded up here.
Welcome. Go ahead and introduce yourself and tell us about your presentation.
Thank you, Chair Black, for having us. We're so excited to be here and share a little bit about what we've learned this past semester on price and quality transparency here in Vermont. My name is Sarah Holmes. I'm a sophomore at Middlebury, from Middlebury.
My name is Eleanor. I'm a senior at Middlebury from Chicago.
My name is Lily McGovern. I am also a senior and I'm from Massachusetts.
Right. So just to dive right in, obviously we've all heard a lot about healthcare costs growing, and especially in Vermont. We know that from our research that Vermont had 22% higher spending compared to the US in 2020. So this is obviously an issue that we're all probably fairly aware of, but there have been a lot of arguments that say increased transparency could help curb this growth in healthcare costs and also improve quality outcomes by giving patients access to price and quality information, and particularly about these things called shoppable services, which we're all probably familiar with as well. The idea behind this is people can kind of choose and do some research on what makes most sense for them to do based on the price and the quality of each service. So yeah, things like imaging, colonoscopies, lab services, cosmetic surgeries. We were looking into this McKinsey study a little bit. They conducted multiple consumer surveys in May of 2023 to determine the impact of federally mandated price transparency. And they found that 89% of consumers were willing to shop for care on at least one healthcare service, and 52% of consumers were likely to see a different provider in return for a $100 incentive. So this is suggesting that patients will make more informed decisions on their care if price transparency data is available. So yeah.
Yeah, so the reason why all of this has come to light in recent years is because there has been a series of federal laws and mandates in the last few years since 2019 that have focused on price and quality transparency. The first few were mandated under the 2019 Executive Order on Improving Healthcare Price and Quality Transparency, which did two main things. First, it required hospitals to publish their pricing data for over 300 shoppable services. And that was supposed to be posted by every single hospital as both a machine readable file and presented in some consumer friendly format that patients would be able to use so that they could compare services and decide where they were going based on the price of them. It also established a health quality roadmap, which aims to align quality data across different collection of data from different federal agencies. But this second piece of the EO never really came to fruition. It only really existed as a concept of a plan and never, fully was formed. And then following that, in 2022 and 2023, there were a series of mandates from the Centers for Medicare and Medicaid Services, or CMS, which required that insurers publish machine readable files for their data with their negotiated rates specifically, and then also so that they were supposed to create transparency tools that their customers could use. So that would relate specifically to their insurance so that customers could look at the rates based on their negotiated rates. Even with these laws in place, there was a study that found that in 2023, only 29% of hospitals were compliant with the federal transparency rule, even though these hospitals were receiving daily fines. These fines started at $300 and then were up to $5,000, and still hospitals were not compliant. And because of this, upon taking office in January, President Trump tried to strengthen these initial rules using his Making America Healthy Again program, which just kind of updated the earlier laws and increased enforcement of them. But unfortunately, as we will see in this presentation, nationally and nationally and in Vermont specifically, hospitals continue to lag behind, and there still isn't great transparency for price or quality. So today we'll be showing you exactly what that means, as well as giving some recommendations for improvement.
Thank you, Lily, for that national overview. We want to go into a little bit more about the state of transparency in Vermont. So through our research of talking to stakeholders, but also looking at all of these hospitals' transparency tools and machine readable files ourselves, we found that they were difficult to navigate, often incomplete, not standardized, hard to find on the websites. Some of them were outdated with information from 2023, and there was also no quality information paired with the price. So if you were patient shopping, you wouldn't be able to look at both of those simultaneously. So we would like to show you a little bit, just like 3 different examples of different tools from the state of Vermont.
Yeah, so the first is from Gifford Medical Center in Randolph. This is published as a consumer-friendly file, but obviously it's not very consumer-friendly at all. It requires a pretty great knowledge of how to work a spreadsheet, what a hospital CPT code is, and how to find your specific procedure. This is not something that the average Vermonter can do. Not even us can really figure it out after looking at it for this whole semester. So obviously it's really hard to navigate. It's very confusing. It's really hard to read. And I also want to note that this data is from 2023. This is the most recent file that's published on their website as of earlier this month when we took this screenshot. So obviously that data isn't super useful because prices have probably changed a lot since then. So as you can see, not a great example.
The second example we want to highlight is from Northwestern Medical Center's price estimator tool on their website. As you can see, it actually does break down the cost fairly well. It shows the cost for procedures and then the total contracted discount, payer-specific negotiated charge. So this is, in theory, useful information, but it has this little disclaimer at the bottom that says the price does not include charges associated with physician services for which you will be billed separately. So it actually is missing a fair amount of the total cost. And it can be hard to know or hard to, have any estimate of what those physician costs might be. So not the most helpful tool.
And then lastly, we want to show you Brattleboro's Hospital. And so this is actually a little bit better because they don't require personal information and they break down the charges a lot more easily for kind of a human to understand by looking at this. But it's important to note that all of these hospitals they're not super uniform in what exactly they're counting in cost. So it's kind of unclear actually if this does include physician services. We would assume that it does, but it's really hard to compare. I mean, this would already take a long time to figure out all the prices for these hospitals, but even if you do, it'd be extremely hard to compare. So we've actually done a little bit of that for you. So this is data that we found earlier in April, and this is the cost of a standard colonoscopy procedure, just the Blue Cross Blue Shield estimated negotiated rate for Vermont hospitals. And so as you can see, those were all the files that we found this data from, and the prices range from $1,400 at Mount Ascutney Hospital to $8,000 at UVM Medical Center. So that's a huge difference. It's almost 6 times the price. And it's unclear of, whether or not that's because you're paying for higher quality or it's just more expensive as a university medical school. But it's hard for patients to know what exactly is this a standard price, if even these are up to date. But yeah, this took many hours and going through lots of spreadsheets and a lot of double checking things. So although this is kind of an easy way to compare, the average consumer would not be able to come up with this quickly.
And we're not sure in these that are we comparing just hospital charges or hospital and physician combined?
Yeah, so I think that's kind of the point that, it's hard to know exactly what these are, just the kind of costs. If you were to look up these are the negotiated rate for the insurance for Blue Cross Blue Shield. So I think some of them include, but like, as you can see from the last ones, we took them from the payer amount allowed and just the, the negotiated charge, which I don't think includes physician services. So it's hard to know actually if, I mean, we too tend to see that UVM price is higher, so it's hard to know exactly, but I do think there is some difference in what exactly they're including as well.
So in terms of quality, the Center for Medicare and Medicaid Services does have this really great tool that's really reliable, but it's not very useful for Vermont. So for example, here we've got, we have some quality metrics relating to complications that arise after procedures at Gifford Medical Center. And this is actually what a lot of Vermont hospitals look like as well. If you look it up, there will be a lot of things that say not available. In some cases, this is because like the services relating to whatever metric it is just aren't being offered. But in this case, these are mostly about ICUs, and Gifford does have a 25-bed ICU. So what it often does reflect is that Vermont hospitals are very small and they have really small sample sizes. And Care Compare won't actually, tools called Care Compare. Care Compare won't actually publish quality results if there's not enough data to be statistically meaningful. So it's really common for rural hospitals like those in Vermont to struggle with, or like struggle to be able to have enough data to produce meaningful statistics. So this means that Vermonters are going to have pretty difficult time comparing quality across hospitals when it's not really available. So we actually, in order to combat this, we would maybe suggest implementing some sort of like a rolling 3-year average of quality metrics just to be able to increase that sample size and produce meaningful results. But again, I mean, in the current moment, it's a bit tricky to navigate quality in Vermont. So.
So we do want to bring your attention to New Hampshire, which we believe is leading the price and quality transparency in the country. And so we were able to come across their New Hampshire Health Cost website. And this is a pretty easy tool that New Hampshire residents can use to compare care, compare services, quality, and prices across all New Hampshire hospitals. We were able to speak with one of the people leading this tool in New Hampshire, and he told us that the site receives around 75,000 visits per month. So we believe that this is kind of like an optimistic, hopeful that something like in Vermont would get something similar because of the rural landscape. But it shows a lot of promise. As you can see, it has also this is the negotiated rate as well for the estimated procedure costs, and you can easily compare it to the statewide average, and then look at the precision of the cost estimate.
Yeah, so another promising aspect of the New Hampshire Health Cost tool is that it also compares quality. And this is kind of the only website that we have been able to find that does both price and quality at the same place. The screenshot specifically shows time spent in the emergency department before discharge, but the website as a whole offers a lot of the same measurements that are offered on the Care Compare website, but they're specific to New Hampshire. So they have either just more data or more specific data. They might use those 3-year rolling averages that Eleanor mentioned. Not entirely sure how they collect their data, but it's specific to New Hampshire. So it has a lot more data, and a lot of the fields that are not available in the Care Compare website are filled out on this website. And especially given the similar demographics of the two states, New Hampshire tool is a great model to consider when taking all of this stuff over to Vermont. I also just want to mention that this is also the only tool that for either price or quality, you can just look at all of the hospitals right in a row instead of going to either of their websites, or even on the Care Compare website, you have to search up each individual hospital to find their quality ratings and just kind of remember in the back of your head what they each look like. And so this one, you can just see there's a bar graph on the side. You can sort them based on their averages, and you can really make the best decision based on that pretty easily.
So based on all of that information that we've done a lot of research on this semester, we have built 3 specific recommendations. So the first one is to encourage hospitals to establish some sort of like a working group and to be able to work with the state to come to an agreement on a standardized format to submit data that's feasible for the hospitals and also reliable and accurate and consumer friendly or able to be read by the people who are actually going to be using them. We also think that the state should work with the Vermont Program for Quality in Healthcare to determine like which quality metrics are going to be most useful to include. They've been really helpful with our research in this process as well. So we think that would be a good way to make sure that the right quality metrics are being posted. And we also want to really ensure that we're not adding to the administrative burden that's already present in hospitals. And that's why we're kind of hoping to work with the hospitals and get them to form this sort of working group so that they're able to make sure this is able to be done by all the hospitals. But we also do really want to ensure compliance. So we're hoping that the Green Mountain Care Board could do this by, in the hospital budget review process, they could kind of check and make sure that things are being complied with. And then we could consider implementing state fines for noncompliance. We could do something similar with what New Hampshire is doing. They just introduced House Bill 743, which says that not only do healthcare entities have to provide estimates of services provided and post notice of patients' rights to request information, and obviously to require them to comply with federal transparency requirements, but it also directs the Department of Health to adopt rules regarding disclosure requirements and also provides assessments for fines of noncompliance. So this is just one model that we could kind of look at to ensure that all these suggestions would actually be used and complied with. So.
Yeah. Our second recommendation is to use that standardized data to build a price and quality transparency dashboard. Similar to New Hampshire's, this is a mock-up of what a tool could look like. And the idea would be that you would be able to easily compare price and quality for different Vermont hospitals. You would be able to include an insurance plan filter that maybe even includes your deductible. So these estimates would be fairly accurate. Also have accessibility tools. So, large font toggle, multilingual support, just like screen reader compatibility, because obviously, Vermont, we have a growing elderly population and we want to make sure that this is accessible to everybody. And also we would like to introduce a rebate program as some sort of incentive for people to use the tool, which Lily will get into.
Yeah, so all of these recommendations are great, but they won't be super useful to the legislature and to the healthcare spending in the state in general until people actually use them. So we recommend first just some sort of marketing or awareness campaign if these tools were implemented, or just around the fact that these, they're not great, but this information is published right now. And I think a lot of people don't know that. And so getting the word out about that would definitely be a good start. And then we also recommend using New Hampshire again as a example. They have a Smart Shopper program that goes along with their health cost tool that provides discounts in the form of rebates for anyone who uses their tool to select their medical service center. So if they can prove that, then they get a rebate on their care. And the person that we spoke with at the New Hampshire Insurance Department suggested that that was definitely a motivator for a lot of people using the tool. And then once these tools and systems are in place, the legislature might also consider passing a right to shop law, which would require insurers to share any savings from the choice of a low-cost medical facility with the patient. So I'll just go through an example. If a patient had a choice between a hospital, this patient is going in for a colonoscopy, let's say, and one hospital is charging $2,000 and the other is charging $6,000. The patient will probably pay the same no matter what, because they have that insurance. They might pay $100 for their colonoscopy. But if they choose that lower cost facility, the insurer would be required to save or to give back some of that $4,000 of savings back to the patient. So that would just be an incentive for the patient to choose that lower cost facility and would result in savings for insurance companies. And I think we all know in Vermont, a lot of our insurance companies are struggling right now. And so this could definitely help them to save some money and reduce healthcare spending in the state in general. That savings amount is typically half of the difference in cost between the chosen option and the average cost in the area, which is a mouthful, but it's definitely a lot of savings for the patient and a lot of savings for the insurer as well. So we want to thank all of you for listening and thank Professor Holmes for organizing all of this. Our contact information is on the screen, although just a note that Eleanor and I are graduating. And then you can also scan this QR code if you'd like to access our one pager, which we will also hand out to you in paper form now.
Thank you so much. I've been sitting here listening to it thumbing through our VCures information, which is sort of what it was hopefully intending to be, and the fact that there's nothing there. So, so it's a good reminder that we still have a lot of work to do in this.
Are there right to shop laws already established in some states? Do you know?
I'm not sure specifically. I know that there are not in Vermont because we don't have any transparency tools, but I think in states that have those better transparency laws, like in New Hampshire, the Smart Shopper program might have been born of a right to shop law, but not sure.
Thank you.
Would you consider expanding it besides hospitals to other services such as nursing homes or surgical services or have you?
Yeah, definitely. I think the idea is that it would be expanded. That's the other thing with the federal laws, that it is mostly centered around hospitals. I think there's maybe some requirements for other medical centers, but the idea would be that any sort of additional medical facility would also have that same sort of reporting, because it's the same type of thing. And a lot of those non-hospital entities are places where shoppable services are provided. Yes.
Casey.
I love this, and I just really appreciate the innovative ideas that you all come here with, and I'm just very intrigued, and just keep up the amazing ideas. I mean, I've heard of like secret shopping of different healthcare providers in order to like give them feedback on the quality of care that they're doing, but this really takes it to the next level by really kind of pressuring the different facilities to really do better. And I think we need more of this kind of thinking. So thank you for bringing us this.
Thank you. I'll just add too that I think what we might not have mentioned is, of course, we want patients to shop for these services, but we've also seen like in New Hampshire that, and other states, that there's just like some sort of public accountability, that even when the hospitals know that they have to publish that data, and for those hospitals to see on that bar chart that they're like the highest and they're 6 times more than another hospital, there is some sort of accountability too. And it's also easy for policymakers to understand because right now for policymakers, it's easy. I think it's pretty hard to compare what the hospitals are charging for different services as well, right?
Topper has a question.
Thanks for coming in. This is wonderful. I'd like to talk about patient satisfaction and the quality score. I'm gonna have an appendix taken out. And did you people come up with any kind of rating on either one of those, patient satisfaction or the quality score, that would be average, that would be good, or that would be excellent? Because along with the price, I'd be looking to see whether they do a good job there.
Definitely. I think that would definitely be something we would suggest for, I mean, again, if the VBQHC says that would be a good metric to include, which I'm assuming it would. I think a lot of quality measurement comes from people's actual experiences. So yeah, I think that's definitely something we would look to include in the dashboard. And yeah, we know from our conversations with stakeholders that patient experience is a really, really important part of measuring quality. It can be a little tricky because obviously it's a little bit subjective to your own experience, but yeah, that would be sufficient.
Did you notice as you were going through there that like a score of 89 was pretty good? Or a score of 95? I mean, I can do that in my head, but I was just trying to, what's halfway decent?
Yeah, I think patient satisfaction would be, we would need to look into more of how you quantify that. Would probably take the form of some sort of survey for patients after the care. But I will add too that the care metrics that we kind of kept coming across were readmission rates. Also, Jason Aziz at New Hampshire Health Cost said that MRSA rates were also really important to them, but also just like, rehospitalization, those sorts of things. So it is kind of hard. At the beginning of this project, we were like, how do you actually quantify quality? But there is a lot of already existing tools out there and metrics provided by the, CMS, but also by BPQ.
I will say as well that the New Hampshire tool offers an average of quality. So for the wait times, that middle performance, it shows which, like based on the other hospitals in New Hampshire, it compares them to each other so that you can see like whether they're below average or above average for New Hampshire. And then the Care Compare tool also compares to the national average. So that's something that could be brought into a tool in Vermont as well.
I see Leslie, but Lori, did I see your hand go? Leslie?
Yeah, this is really amazing and interesting, and I'd like to do it tomorrow, so great. But I'm wondering, I worked in primary care, and I'm just wondering, when you have choice, like a patient making a choice to go here or there, what are the logistics of an order and getting information back? And you may not have come across any of that kind of information, but it's something that I wonder about when we have that kind of choice. Does that question make sense?
Sure, about like in terms of data, or what are you, sorry?
I'm actually thinking about how it actually works. Like you get to choose because you like that price and you like that quality, but it's the hospital across the state. How does it work that you get your procedure done there? Does your primary care provider order it there and then get the result? And that you may not have come across any data or information about that, but I was just curious if you did.
I'm not sure off the top of my head, like what, I don't know if we saw any specific data about that, but I think also part of the idea with implementing this tool is that primary care providers could also use this tool and use it to refer patients. So rather than just saying like, all right, I'll write up a, script for you to get this procedure done at this hospital, they could go into this website themselves and kind of figure out like, okay, what's going to make the most sense for me to refer them to. And I do know obviously in Vermont, transportation is kind of a bit of an issue as well, because obviously even if the cheapest option is if you can see it, but if it's 3 hours away, that's probably not going to be the most helpful thing. But I think the fact that the New Hampshire tool has had so much success and so many people are actively like using that tool kind of gives us a little bit of hope that people will be able to figure out the means of transportation for the sake of saving $4,000 on a colonoscopy for their insurance company or something.
Well, I think what you said is really important, is that it brings the ordering clinician into the choice making.
Yeah.
And I think that's very cool. So thank you. Great input.
Thank you. Thanks so much. Really enjoyed that. From someone has all the hospital's price transparency tools, you've given me an idea of something to go forward with, because they're a nightmare. All right, next up.
Well done.
Thank you so much.
Next up, a topic that we were delving a little bit into yesterday, prescription pricing.
You need that? Okay, we'll take that. Anyone?
Who just said, no, where's no outside?
No one wants kids.
Oh, okay. Everybody all set?
Yes.
All right. Welcome.
So we are prescription managers. We spent our semester researching
prescription drug prices in Vermont and the various supply chain entities and other factors that contribute towards our uniquely high costs of prescription drugs. And in our presentation, we decided to focus specifically on the role of PBMs and 340B covered entities and the ways in which the state can strengthen regulation around these groups and understanding excessive supply chain.
And my name is Ellie Katie, and I'm a senior at Middlebury. I'm from Milwaukee, Wisconsin.
And I'm Maggie, I'm also a senior and I'm from New Jersey. Okay. First, just for a national overview, I'm sure we're all aware of some of this stuff, but the rising cost of prescription drugs has been putting an increasingly large strain on patients and insurance providers across the country. We already spend more per capita on healthcare than any other country in the world, and prescription drugs are expected to be the fastest growing category of health spending in the coming decade. The $603 billion that we spent on prescription drugs in 2022 already represents a 91% increase in drug spending from 2 decades ago. And these alarming trends can be partially attributed to the fact that non-manufacturer supply chain entities are taking an increasing share of drug spending. So in 2023, less than half of every dollar spent on prescription drugs was actually received by manufacturers. Instead, 25% of all spending went directly to pharmacy benefit managers, while another 10% was tied to 340B provider markups and pharmacy margins. And this is because the nature of our medical supply chain is very highly fragmented, opaque, complex, allows for all of these different intermediaries to siphon off staggering profits throughout the supply chain. So obviously, rising costs are straining both public and private insurance companies as well as patients who are facing increasing cost-sharing burdens from their prescriptions.
So in the state of Vermont, Vermont hospital-administered drug price ups are much higher than hospitals across the country. According to this graph, which is taken from the 2024 RAND report, Vermont administered or hospital-administered drug prices are over 500% of the average sales price as compared to other states, which average around 300 to 400% above the average sales price. So this places a lot of financial pressure on private insurers. Another example is if you were to go to the Rutland Regional Medical Center and receive a drug known as Remicade, which is an immunosuppressant, and if you were insured by Blue Cross Blue Shield of Vermont, Blue Cross Blue Shield of Vermont would have to reimburse the hospital over 1,400% of the average sales price. So again, this is demonstrating that financial pressure that falls on commercial insurers. And what ends up happening is that commercial insurers have to increase their premiums or their cost sharing in order to combat some of these rising prices in drugs. And this can reduce affordability and access for individuals in need of prescription drug medication. And practices like skipping doses or not filling prescriptions become common, which can place great pressure on the Vermont healthcare system as well.
Okay, before we get into our specific recommendations, just thought it would be useful to provide you guys with a quick refresher on the 2 most important terms that we will be referencing again and again throughout the rest of the presentation. So first one, pharmacy benefit managers, PBMs. A lot of people hate them.
Control my boo.
They act as middlemen between manufacturers and pharmacies, and their role in the healthcare system is determining prices and access to drugs. They also make what are called formularies, which are the list of covered drugs by a certain health plan. And while they claim to fulfill an important role in the medical supply chain, they also receive quite a bit of criticism for charging high markups on drugs, the exact percentages of which are like generally unknown by policymakers and consumers because they consider their markups to be trade secrets. And we also focus our research on the 340B drug pricing program, which again is a federal program that required drug manufacturers to offer discounts to qualifying hospitals. This program was designed to support hospitals that mainly serve low-income or underinsured populations. And in Vermont, 14 out of the 15 hospitals participate in 340B. So recent literature has cited some concerns surrounding the 340B drug pricing program. For example, according to the New England Journal of Medicine, hospitals eligible for 340B are more likely to have higher markups than non-eligible hospitals. And hospitals do state that they use this 340B revenue, which is generated from the discounts that they purchase the drugs for, as well as their ability to mark up the price of the drugs in order to support services and programs that could impact low-income individuals. However, we just don't know exactly how hospitals are using this 340B revenue. Currently, hospitals are not required to report how this 340B revenue is being spent. We do know that there is a bill in the Vermont legislature that, if passed, would require hospitals to report this data and increase transparency around the 340B drug pricing program. And so we have done our research on what this transparency law could look like in the state of Vermont. And we believe that Minnesota provides a really good example. In 2023, Minnesota passed a statute which requires all 340B covered entities to report acquisition costs for drugs, total payments received from patients and insurers, contract pharmacy costs, and the number of prescriptions filled for 340B drugs. They provide a really good example as they published a report this past fall, which details some of their findings and challenges. So some of their findings that they reported was that across all 340B covered entities in the state of Minnesota, $630 million was generated in 340B revenue. They found that 70% of that $630 million was contributed by only 17 drug families, indicating that high-cost, highly complex specialty drugs are major contributors of 340B revenue. The Minnesota State report also did not disclose a summary of how 340B revenue was utilized, so there still is some uncertainty. But they did report some of their challenges. So they stated that the $630 million that they accounted for in 340B revenue probably only accounts for half of the actual revenue generated across all 340B covered entities. They found that there was a lack of clarity in the original statute surrounding office administered drugs, and they struggled a little bit with some of their data collection. So what does this mean for Vermont is that if Vermont would enact a law that would increase transparency around 340B, there would need to be a consideration of the data collection methods, Vermont's clinical capacity, and some of the barriers that Vermont could face in data collection.
I have a question real quick. Do you know, and we looked at Minnesota.
Yeah.
We're doing 266 originally. The 630 million that was reported, is that revenue that was just revenue generated between the 340B acquisition and what the acquisition would have been without a 340B, or was it just all revenue based on a 340B drug? Because I mean, you showed the chart before where actually the 340B drugs are priced higher than.
Yes.
Do you know if that 630 million, was it on just all of the drugs revenue, or just in that area between what they got it for and what they would have gotten it for if not?
I believe.
I'm looking at the report right now. They defined it as gross 340B revenue minus external operational costs. Payments received minus the sum of acquisition costs, contract pharmacy costs, and other external costs.
That answers it. Thank you.
Okay, so where does the Minnesota bill lead us? Now getting into our own, this first set of recommendations revolves around increasing transparency. So we know that H266 is one attempt at solving some of the transparency issues around 340B in Vermont by requiring hospitals to report on their acquisition costs, payments, and how revenues are being used. The bill is very similar to the 340B transparency bill passed in Minnesota, and therefore we can learn from some of the shortcomings of that bill in order to improve our own. So Ellie just mentioned that there was a lot of ambiguity in the original statute's language around the specific reporting requirements for hospitals. So this allowed them to skirt some of their reporting obligations by not submitting their revenues for 340B office administered drugs, which were estimated to account for as much as 80% of all 340B spending. So the report on their 340B revenues was a massive underestimate. In order to prevent this same misunderstanding around what drugs need to be reported, we think that we should specify the language in H266 section 2 so that we include the phrase dispensed and administered to patients. This is what Minnesota updated their language to in the 2024 statute after running into all of those data collection barriers because the language wasn't clear enough. So hopefully this will just provide some clarity to hospitals that they need to be reporting revenues for all 340B drugs, including those administered in office. And second transparency recommendation revolves around PBMs. So we suggest that PBM should be required to submit an annual report detailing their 340B reimbursement methodology in order to halt their ability to engage in spread pricing tactics. So essentially, I'm sure you guys are aware, but the problem right now is that PBMs that own their own pharmacies have been able to misappropriate the savings available through the 340B program by diverting discounts away from patients and taking them in as profits, right? So 340B eligible hospitals can choose to contract out with pharmacies. A lot of these pharmacies are owned by PBMs to dispense their drugs. And then the PBM-owned pharmacies will buy the drugs at the discounted 340B rate and then sell the same drugs to other payers at a much higher rate. So they're essentially undermining the patient cost-saving intent of the 340B program. And although I know that there are some proposed regulations under H266 that aim to prevent PBMs from engaging in these discriminatory pricing tactics around 340B. I think that it would also be important to ramp up PBM reporting requirements for which would allow regulators to more easily identify when they are actually engaging in these unscrupulous 340B profit seeking. So right now, Act 127 states that the Commissioner of Financial Regulation may examine or audit the books and records of a PBM in order to determine whether their reimbursement practices are in compliance with regulations. But scrutinizing their records in this way is probably going to be very time consuming and complicated, and the data might be hard to interpret. So that's why we recommend that PBM should be required to submit an annual reimbursement report to the Department of Financial Regulation that presents their reimbursement methodology in a clear and legible and standardized format. We should include information like their median reimbursement rates paid to both covered entities and contract pharmacies for both 340B drugs and non-340B providers and pharmacies for the same drugs, descriptions of any different reimbursement methodology applied to 340B claims versus non-340B claims, and then any other fees or adjustments applied to 340B claims. And one idea is that the submission of this report could be required as a condition of obtaining or maintaining licensure to operate in the state. And yeah, hopefully this would allow us to identify more easily spread pricing tactics around 340B.
Our second recommendation is to cap hospital administered drug costs at 120% of their average sales price for commercial insurers. And so why 120%? Firstly, Medicare reimburses their drugs at 106%, and they state that that 6% is to be used to cover administrative and handling fees. So we imagine that that 20% would allow hospitals to still sufficiently cover those administrative fees, but also 340B hospitals are purchasing drugs at a discounted rate. And according to the Centers for Medicare and Medicaid, they estimate that 340B hospitals are probably purchasing these drugs at around 65% of their average sales price, meaning that if this cap was enacted, hospitals would still be permitted a 55% price markup, allowing them to still generate 340B revenue to support some of those programs and services for low-income individuals. We do recognize that there would be an impact on 340B revenue. However, we just don't exactly know because hospitals do not report how they are currently spending their 340B revenue. What we do know is that there would be great cost savings by Blue Cross Blue Shield of Vermont, who report that 90% of their total cost savings would be generated from just 3 hospitals, the UVM Medical Center, Central Vermont Medical Center, and the Rutland Regional Medical Center. So we also want to talk about some of our proposal limitations. Again, we recognize that hospitals do rely on some of this revenue to support services. But if you look at some of the savings generated by Blue Cross Blue Shield of Vermont in a different way, the majority of the financial impact would be on just those 3 hospitals. And they ended fiscal year 2024 with positive operating margins, indicating that these policies are financially feasible.
And looking towards the bright side, at the end of the day, like we know that there are a lot of other efforts to improve the state's healthcare system underway, and we acknowledge that our proposals can't be effectively pursued without other major policy initiatives that also work towards the goal of long-term healthcare system sustainability in the state. So our ideas to reduce prescription drug prices represent just a small piece of a much larger solution. But the big idea here is that the state needs to find a way to continue providing essential medical services in rural counties, and we cannot be doing this at the expense of patients. We know that access to prescription drugs reduces the likelihood of expensive medical visits. So pursuing strategies like this that increase drug affordability in order to prevent unnecessary hospital visits is an advantageous trade-off that both reduces costs to insurance companies and benefits the patients themselves. And a healthcare system that is subsidized on the backs of each victim life-saving medication is not a sustainable system.
We also would love to extend our gratitude to the many individuals who supported us throughout this process. Thank you to Noah Montemariano and Catherine O'Neill from the Green Mountain Care Board, as well as representatives from Blue Cross Blue Shield of Vermont, Dr. Tom Weigel and Nancy Hogue, and representatives from Vermont Legal Aid Healthcare Advocate Mike Fisher and Charles Becker. And finally, thank you, Professor Holmes, for supporting us throughout this project and for instilling a passion for working on complex healthcare challenges. And thank you all for inviting us here today. We are very thankful for the opportunity to present. Thank you.
Yeah. And good luck in your careers. I'm curious.
Where to next?
I'm going to law school.
Yeah, I actually graduate next February, and I'm hoping to go into healthcare policy or healthcare administration. And the third member of our group who was not able to participate is going to go into healthcare research or healthcare policy as well.
Okay, great. Yeah, thank you for sharing that. Yeah.
Any questions?
very timely.
Yeah.
considering Our conversation yesterday that we had in this committee, because we will have 266 coming back to us. Yeah, so this is Representative Mari Cordes, who H233 was her baby. I hate to. So anyways, thank you.
Thank you.
Thank you. Well done, everybody.
Everybody. And I don't mean to like say anything mean about the usual witnesses we have in here, but the information you have given us today is frankly some of the most valuable information we've had. So thank you.
Thank you.
Thank you.
Thank you for the opportunity. And thank you for all the rest. I mean, I have all the finals.
Oh, you got for lunch first?
Yeah, maybe lunch.
Lunch first?
Maybe lunch. I want to go back to the red hen.
So we have two choices. We were scheduled for a break, and then we have Catherine O'Neill from the Green Mountain Care Board on 266. And then after that, we're done. Would you rather just do that and then we'll be done, or do you want to take a short break and come back?